So the way that we do this, Carlos, is we actually have the ESI of the day introduce you, and she will give a short talk prior to your talk, somewhat related. And we're really looking forward to hearing from Jennifer Jain. So Jennifer Jain is going to talk about mechanisms linking gender-based violence to worse HIV treatment and care outcomes among women in the US. And Jennifer is a postdoc in the Substance Use Disorders Treatment and Services Research Traineeship in the Department of Psychiatry, though she is moving over to become faculty after just receiving an amazing score in her K. She has content expertise in substance use research, training in epi methods, and today she's going to talk to us about those women who use substances and how to improve their outcomes. So thank you, Jennifer, for being here.
Thank you so much for that introduction. I'll go ahead and share my screen. Let's see.
We are seeing your desktop, but not your, yeah, there it is.
Thanks. Okay, there we go. Excellent. So thank you so much for having me here today. It's really a pleasure to be here. And I just wanted to begin by mentioning one of the things that excites me the most, which is exploring the intersection of substance use and infectious diseases, including HIV, among women who use drugs in the United States and beyond. And so without further ado, the title of my talk is Mechanisms Linking Gender-Based Violence to Worse HIV Treatment and Care Outcomes Among Women in the United States. So significant gaps in the HIV care continuum persist among women in the United States, with only 58% retained in care and approximately 50 to 60% virally suppressed. And these disparities along the HIV care continuum are often driven by social and behavioral factors, including gender-based violence and substance use. So we know that among women living with HIV in the United States, over half have reported experiencing intimate partner violence, which is a common type of gender-based violence, and more than twice the rate of experiences of violence among women in the general population. We also know that substance use is common among people living with HIV and has been identified as a mechanism to cope with trauma related from experience or stemming from experiences with gender-based violence. And we also know that HIV treatment and care outcomes, such as viral suppression and adherence, are worse among women who use drugs compared to their counterparts who don't use drugs. But what we don't know much about, or what I was interested in exploring in this study, was understanding whether or not substance use played a role in linking experiences of gender-based violence with worse outcomes along the HIV care continuum. And so the purpose of this study was to test whether substance use mediated the relationship between gender-based violence and worse HIV treatment and care outcomes among women throughout the United States. And of course, my central hypothesis was that substance use would explain, at least partially, the relationship between gender-based violence and poor outcomes along the HIV care continuum. And so to answer my overarching research question and test my main hypothesis, I leveraged longitudinal data from the Women's Interagency HIV study from all of these sites that you can see here throughout the United States. And data were collected semi-annually between 2013 and 2016. And this study includes approximately 1,700 women. The two primary outcomes for this study were engagement in care, poor engagement in care, defined as having missed at least one HIV care appointment without rescheduling. And again, all data were captured in the past 6 months. So this is in the past 6 months. And suboptimal adherence, which was self-reported and defined as reporting an adherence rate of less than 95%. The primary explanatory variable was gender-based violence, which included any experiences of physical, sexual, emotional, or psychological abuse. My two mediators of interest were illicit drug use, excluding marijuana, and heavy drinking, and then I measured several covariates, which are listed here, that I controlled for in all of the adjusted analyses. So the two main analyses that I performed were I applied mixed effects logistic regression with a random intercept to account for repeated measures per person, and then I performed mediation analyses consistent with a product method to test the amount, or to estimate the amount that gender-based violence, of the relationship between gender-based violence and these two HIV outcomes, worked through these mediators of interest. And so here's just sort of a snapshot of some baseline characteristics of the study sample. And so approximately 70% of women identified as Black or African American, 75% reported earning up to $24,000 annually, 61% reported ever experiencing gender-based violence, while only 5% reported experiencing gender-based violence in the past 6 months. 11 and 10% reported heavy drinking and illicit drug use, respectively, and 17 and 15% reported suboptimal adherence and poor engagement in care, respectively. And here are the results from the multi-level logistic regression analyses broken down by outcome. And so what this shows you is that women who reported experiencing recent gender-based violence, women who reported engaging in heavy drinking and illicit drug use, all had higher odds of suboptimal adherence and poor engagement in care compared to women who didn't report experiencing violence or engaging in heavy drinking or illicit drug use. And these are the results from the mediation analyses, again broken down by outcome. And these results show you that both heavy drinking and illicit drug use mediated a healthy proportion of the total effect of gender-based violence on each of these two HIV outcomes. And interestingly, illicit drug use mediated a larger proportion of these relationships compared to heavy drinking. So I'd now like to acknowledge a couple of the limitations associated with my study. And so, although the use of lagged variables would have strengthened this analysis and my ability to identify causal links, I do theorize that bidirectional relationships may exist between the key variables of interest in this study, and also that the temporal sequencing between these key variables may occur with an interval smaller than when these data were captured, which again was every 6 months. And there are a couple of other standard limitations noted here, including the use of non-probability sampling methods to recruit women into the study, and my reliance on self-reported data of several sensitive behaviors. Despite these limitations, however, I think we can draw a few important conclusions from this work. The first being that substance use does appear to be a key underlying mechanism through which gender-based violence adversely impacts HIV treatment and care among women throughout the United States, which tells us that perhaps in order to achieve optimal HIV continua outcomes among women, interventions might want to consider addressing the combined epidemics of violence, substance use, and HIV. And one potential way of doing this in future female-centered interventions is by very carefully and thoughtfully integrating harm reduction-based substance use treatment services with trauma-informed HIV care services, along with other female-centered services, such as potentially reproductive health care for women who are planning to become pregnant or have children, as well as childcare services so women can access both substance use treatment and HIV care. And I think this work ties really nicely into the future directions of my program of research, which will focus on developing, adapting, and testing theory-driven interventions to improve both HIV prevention and treatment among women who use drugs in the United States and beyond. And with that, I'd like to acknowledge all of the collaborators on this work, as well as my mentors, and thank everyone for their support, and thank you for your time and attention. And I would now like to welcome any questions or comments that you may have. Stop sharing here.
Thanks, Jennifer. And Aisha has a question for you.
Yes, please.
You know, I was mostly clapping, but I
Hey,
can ask a question. Jennifer, that's phenomenal work. Thank you so much for doing it. My question for you was, you know, you're sharing quantitative data, which is very exciting and important. I'm curious whether in your work that may or may not have been qualitative, or in others, in thinking about the pathway between gender-based violence, substance use potentially to cope or not, or as you mentioned, could be bidirectional. And then HIV outcomes that are suboptimal. Do you have a sense of qualitative information around use, patterns of use or reasons for use that do involve coping with the violence or not?
Yeah, that's a great question. Thank you very much. So, I have not actually conducted any qualitative research examining these actually in general or examining these research questions. But what we do know from the literature is that substance use, again, has been identified as a potential coping mechanism to deal with trauma in general. And I think I'm thinking of Carol Dawson-Rose, who's on this call, who could probably speak much more to this. But yeah, and I think, but again, I think these relationships, like I was saying earlier, could be bidirectional in that experiences of substance use may lead to experiences of violence in some way. It might be sort of cyclical. And so it's hard to sort of tease these things apart. And so I agree that qualitative research might be able to get at some of the nuances of these relationships better than these quantitative methods.
Valerie, last question, and then we can go on to introduce Dr. Del Rio.
Okay, great. Great job, Jenny. That was, excuse me, great to hear more insights into this work. You hinted at this in in the limitation slide, but I'm curious whether you or anyone else working in WISE has compared the levels of gender-based violence there. Is it representative of what we know of gender-based violence and the larger population of women with HIV? And I know it's hard when people use different metrics to assess it, but I'm wondering if you've got a sense of that.
Mm-hmm. Thank you. That's a great question. So one of the data points that I presented in the background was from a researcher at UCSF. I'm going to probably mispronounce his last name, but it's Edward, I think it's Matchinger. And he conducts research among women living with HIV. And according to his study, approximately 55% of women reported ever experiencing intimate partner violence, which of course is a common type of gender-based violence, which is consistent with what we're seeing. We saw 61% in this sample reporting ever experiencing any type of gender-based violence. However, I was surprised that recent gender-based violence in the past 6 months was relatively low. It was much lower than I anticipated it being, at only 5%.
Okay, thank you so much. And we'll go on to Carlos.
Thank you so much. Okay, so now it's my great pleasure to introduce our speaker today, Dr. Carlos Del Rio, who is a distinguished professor of medicine in the Division of Infectious Diseases at Emory University, the Executive Associate Dean for Emory at Grady, and a professor of global health and of epidemiology at the Rollins School of Public Health. Dr. Del Rio is a native of Mexico and attended medical school at Universidad de La Salle, graduating in 1983. His internal medicine and infectious diseases residencies were completed at Emory University. Dr. Del Rio's research focuses on the early diagnosis, access to care, engagement in care, compliance with antiretrovirals, and the prevention of HIV infection. He has worked for over a decade with hard-to-reach populations, including people who use drugs, to improve outcomes of those infected with HIV and to prevent infection with those at high risk. He is also interested in the translation of research findings into practice and policy. During the COVID-19 pandemic, Dr. Del Rio has been a leader locally and nationally, doing research, developing policies, writing scientific publications, and making countless media appearances. He has advised municipal, state, and national leaders, including the Mayor of Atlanta, Tyler Perry Studios, the NCAA, the USTA, Delta Airlines, Truist Bank, the Atlanta Symphony Orchestra, and the Atlanta Opera, among others. He also serves on the National Advisory Committee of the COVID-19 Collaborative, which focuses on developing consensus recommendations and engaging with US leaders on effective policy and coronavirus response. He's an investigator on the Moderna COVID-19 vaccine clinical trial, as well as on the ACTT studies that led to the approval of remdesivir, among other drugs. Dr. Del Rio's work is both inspiring and transformative. The title of his talk today is Lessons from HIV that can be applied to COVID. Please join me in welcoming Dr. Del Rio.
Thank you, Jennifer, and thank you for the kind introduction, and thank you for the invitation to my friends from the UCSF CFAR. I really enjoyed your presentation, Jennifer. And again, it shows us that when we take care of patients and we think about their ability to do or not do what we think is good for them from a medical perspective, it really frequently it boils down to social determinants of health and issues that are sometimes beyond our control, right? And something that creates a lot of and what the patient's priorities may be are very different than what our priorities are. We may think the most important thing is for that person to come to clinic and get their antiretrovirals, when for that person the most important thing may be to avoid a difficult home situation or something like that. So obviously, I think work like yours is incredibly complementary, because as clinicians we don't normally think about those things, and we tend to just think so we tend to over medicalize things. I had some slides, but I'll talk a little bit about what have been the lessons from COVID applicable to the HIV pandemic. I think all of us have learned many important lessons as a result of this. But let me just start by stating that I think all of you here obviously know about the numbers, so I'm not going to spend time there, and about how the one thing that I think is really critical is how the racial and ethnic disparities on this pandemic has been central. And that is really no different than the HIV pandemic, right? Whether you look at HIV, where still the great majority, 55% of new infections in our country are among racial and ethnic minorities, and you look at the recent CDC data about lifetime risk, one in 27 African-American men and 1 in 75 African-American women are at risk of HIV. So when you think about HIV globally, whether it's globally or locally, is primarily a problem of people of color. Now, that's not just related to infectious disease. If you think about other diseases, and I put here, hypertension, diabetes, other problems, African Americans and Hispanics have higher rates of all major chronic conditions, and they have a disproportionate impact that then leads to, led to severe, outcomes in COVID and increasing death in minorities. And the question we need to ask ourselves are the whys, right? And I think, James Hildreth, who is the president of Meharry, presented this slide at NIDA Council, and it basically talks about, again, how we have, sort of how racism needs to be recognized as social determinants of health, and how it is a combination of a lot of the things, right? It's poor access to health information, is lack of medical care, is poorly managed medical conditions, is multi-generational household, is mass incarceration, is mistrust of the medical healthcare system, is low wage jobs, is wealth gap, is low access to technologies. All those things combined that bring a lot of the problems that we're seeing. And we may be focusing on one, your question may be, why are we having low vaccination rates in African Americans? But really it's a combination of factors that really leads to this, and why racism needs to be recognized as social determinant of health. Now, stigma is the other thing, the other important lesson. Stigma has been something that has lived from the beginning of the HIV pandemic, continues to be a problem. And we saw how stigma was also part of the COVID response, and how stigma just became part of how we think about this infection. And there are certain things, for example, the talking about a pandemic of the unvaccinated really never helped increase the number of people who wanted to get vaccinated. As I told even Dr. Walensky once, when she said for the first time the pandemic on the unvaccinated, I said, throughout the pandemic, this has been a pandemic of the unvaccinated. Before we had vaccines, there was a pandemic of the unvaccinated. So I think categorizing people is something that leads you, and whether you think about talking about super spreaders or intentional. So we need to think about our language. And I think if you haven't read it, I recommend reading Susan Sontag's books, AIDS and its Metaphors. And I think it's a really good read about what language does and how we are using language in ways that can be problematic. So what are the lessons that are applicable to HIV? So I thought about 10 lessons that are important. Number one is to think about harm reduction, now risk elimination. Right now we have this tension about zero COVID versus let's live with COVID. I mean, it's all about risk, not, eliminating risk versus harm reduction approach. I think we need to eliminate any type of stigma and discrimination. We need to focus on human rights and a gender perspective. We need to realize that trust is more important than testing. We need to get people to get their trust, and trust is important and must be earned. We need to involve all affected parties in the response. I think one great contribution of the HIV response to the COVID response is that we know how to involve community. We have worked with community, and that was critical in the COVID response. Again, I go back to the importance of information and language. To think about attention of the most vulnerable people, we need to really think about how we think about protecting the most vulnerable. And the fact that, for example, we're losing funding right now for things like testing and treatment for those that are insured is really very concerning, right? I think we need to stop blaming individuals for system failures and realizing that we need a health system that actually provides care. I think we need to help people with resilience. We need to think globally and act locally. We need to continue to act locally, but don't forget the global pandemic. And finally, we need to realize that scientific and public health efforts require multidisciplinary teams. So I'm not going to spend a lot of time on health disparities, but again, I go back to this issue about, always think about health inequalities. In every single pandemic, we have to anticipate health inequalities. And we need to create an enabling environment to support behavior change. There's no point in telling people to change their behavior if we don't provide the environment to do so. And I think risk reduction in HIV is a critical example of that. I think protecting our healthcare personnel is important. I think humility is essential. And again, thinking about how love can be fatal, right? How COVID has turned every man, woman, and child into potential serial killer. And how we learned that from HIV. I mean, what's their words of thinking that potentially you could infect somebody with a deadly virus through the act of love. I think we learn a lot about communicating, and the HIV response, there's a lot of things that we learned that I think are important to COVID. Never overlook the basics. Focus on normalizing, not on moralizing. It's really hard to tell people assessing personal risk, but it's really important that we realize that most people aren't able to do this. I think asymptomatic people are important. I think responsibility lies with everyone. I think acknowledging the disproportionate impact without furthering stigma is critically important, and it's a very tough line to walk. We need to always watch for unintentional stigma. I think we need to be careful not to message in a vacuum, but really provide all the information about why we're messaging that way. And then thinking about how do we look ahead about messaging, about living with COVID, about how do we sort of, HIV has not gone away, but we've learned how to adapt to an environment where there's HIV, and we need to do something similar with COVID. I think treatment as prevention is something important. We need to start thinking about how do we treat people as a way to prevent future infections, not just prevention as primary infection. And I think, could you hold a minute?
Bring them up.
Yeah. And I think, think about the beginning of the HIV epidemic, in which, we only had one drug, ACT, and how far we've gone from having one drug, how now we have combination therapy, and how that changed the course of the pandemic. And again, we need to think about the global response, how we responded globally. And it took many years, but once we did that, we really changed the course of the disease. So I think thinking about the HIV pandemic and its timeline is really important as we think about the COVID response. And with that, I'll end and happy to now take any questions and talk about what we need to do going forward.
Thank you so much, Carlos. That was great. And I think it is exactly you put it better than anyone I know, in the sense that we, I think, didn't learn enough from HIV and how to message, and the compassion and the harm reduction that we used during HIV to message about COVID. And I agree with you that I saw a very moralistic and stigmatizing approach to our messaging. I wanted to ask you, and I know there's going to be a lot of questions, but I wanted to start because you live in a very different state than we do, where we have high rates of vaccination, where there was a lot of work here with Diane and others that worked with communities. But what was the work that happened with communities around vaccine uptake in Atlanta? Because that, to me, was one of the biggest lessons from HIV, is that you have the right messengers when you're talking to different communities about vaccines. So what happened in your setting?
You know, a lot has been done, and a lot has been tried to be done. I think two things have been impacting the rates of vaccination. Number one is, you know, public health and pandemics and health is always political, but it had never been partisan. And I think the partisanship on this pandemic has been a very unfortunate thing, and something that we have to learn about, because I think that clearly was critical. And number two is that misinformation really drove a lot of what happened. And I think at the end of the day, it wasn't the, could you give me a second? Let me just
Yes. And I would just encourage everyone to, I see Diane has her hand up, but just put your hand up, so then we'll call on you next, and you become on the left hand of the screen by doing that. Okay, go ahead.
So I think the other thing was obviously a lot of misinformation, right? And there was particularly relevant misinformation that I think was intentionally targeted to get some communities to mistrust vaccination. And we have worked very hard with communities and with, you know, church leaders and with community leaders, but I think there's still a group of individuals out there who are highly hesitant of vaccination. And I have found the three biggest detractors to vaccination are, you know, the idea, you know, that this is going to affect fertility. And, you know, when you have a major, you know, pop star say, you know, my brother or my cousin or whoever it was received the vaccine and his testicles atrophied, that doesn't help, right? No matter what I say, at that point in time, you lose a bunch of people. So the component of this is going to affect fertility is a big one. The second one is the myth that, you know, this is of no benefit to young people, and that young people are not going to get sick, and therefore they don't need to worry about it. And I think the third one is the novelty. We weren't able to message that these vaccines, even though they were new, they were not new. It was, you know, in fact, we've done vaccination for a long time. Technology may be different, but, you know, I mean, come on, people go and buy a cell phone, right? I mean, it's a new technology, and you don't wait, you know, you don't go back to your rotary phone because that's a more reliable technology. You go forward with technology. And I think we weren't able to message how technology had gotten us to this new vaccines, and we continue to call it, you know, sort of this novel, this new technology. And people in general are very afraid of something that is new, that quite frankly hasn't been vetted well enough. And I think we were never able to do the public health messaging necessary to counteract those myths.
Yeah. Thank you, Diane.
Oh, thanks, Carlos. Great to see you and wonderful talk. Maybe two quick comments. Just building on what you said, then I wanted to bring up one other topic was, just remember in HIV, we started out very partisan and we moved to bipartisan. So we cannot give up. This is clearly one of the major challenges we have right now with COVID. And, you know, one of the things that we have in California is this sordid history of a forced sterilization in Latino communities. And I was just thinking about what you said, you know, just about reasons why people don't get vaccinated. But the point I wanted to make, Carlos, maybe for you to comment on, this is a moment for us also to recruit the next generation in all aspects of science. We really need to address pandemics, starting with our data systems, which are totally broken. We need to get, you know, better technology, better data systems. Our colleagues in Europe have put us to shame just in terms of what can be done with data. And then I think, all the types of science, like all the people on this call, all the young investigators, this is a moment where many of you are doing research in this area. It's very exciting, and we need to really support and welcome that. And then also, Carlos, building on what you said about multi-sector research, that we have to be reaching out across domains of science and doing kind of rigorous work. So I guess it's the pipeline argument too, and maybe if you could make some comments on that.
Yeah, I'll start with the intersectionality and the interdisciplinary. I think if you look at prior pandemic plans, all the pandemic plans that were done primarily around influenza, I mean, none of them said involve anthropologists and involve sociologists. And, it's not like we didn't know that, I mean, in the 2019, in the 1919 flu pandemic, people didn't want to wear masks, but we never said, how are we going to deal with that? How are the sociologists? How are the psychologists going to get involved? How are we going to work with community? So I think even pandemic preparedness plans, even at the local hospital level, we have to involve people working in sciences beyond medicine and public health. And I think that to me is a really important lesson. The other one is obviously what you said is absolutely right. Is how do we find a common ground that allows the partisanship to mitigate? How do we think a way to say, look, this is, I think it's no point on saying, well, people that voted for Trump were more likely to die of COVID. Well, how do we make that, transform that into, hey, what can we do to decrease that? Why is that not acceptable? Why do we need to say that is not, we should be just as sad if they died than anybody else? And what are the action plans that we need to put in place in order to make that happen? I think we haven't done that. And I think part of it has been that I think everybody has retreated to their own camp. And I think, social media hasn't helped because everybody listens to their own echo chamber, and the echo chambers are very, very what you want to hear. So I think we're going to also, the point I'm trying to get is that I think we also need to get, the science of communication, I think it's really important. How do you communicate to people? How do we involve our best communicators in figuring out how do we get them to understand how to better communicate now and in the future? How do we communicate in future pandemics? I think in HIV, we learned very clearly that telling people, you're going to die of AIDS was not the good way to communicate. Yet we did it again with COVID, right? And somehow we haven't done the necessary training and communication. Now, finally getting to science and next generation, I think this is one of the most exciting times to be in science, and we need to get that across, and we need to figure out how do we get, not only the next generation of people interested in science, but the next generation interested in infectious disease. And I think, many of us, you, me, and others, went into infectious disease because our experience with HIV. I'm sure there's going to be a lot of people that are going to go into science and are going to go into infectious disease because they're interested in pandemics, because they're interested in responding to those pandemics. And in that respect, we need to show that this has actually been rewarding. I think for many of us, the message out there has been, this has been exhausting and people are quitting. We need to get the message, the message has to be the opposite, right? This is incredibly exciting, and this is how many careers are being made. People that, all of a sudden are becoming leaders in their fields that in the past were, Ralph Barrick was an obscure scientist until COVID hit, right? So how do we get that next generation of saying what you're doing is incredibly exciting? Because in fact, there's so much work that needs to be done around COVID still. There'll be new drugs developed for respiratory infections. There's probably a new era of vaccinology happening, a new area of understanding a condition like long COVID, I think is incredibly interesting and could have tremendous implications, not only for infectious diseases, but for aging process and for chronic diseases in general. So I think it's actually a really exciting time to be in science and to be in research. And we need to make that very apparent to our, students, to our trainees, because we want to recruit the next generation. It needs to be even, more successful than ours was against HIV. We yet to be able to develop a vaccine, right?
I'm very terrified that this politicization will turn people against infectious disease because it's so interesting. People are maybe tired of hearing about it. So hopefully we can work with that, CFARs and everything else to increase interest. I see that I want to actually call on some of our young investigators who are really interested and excited to have you speak here. That would be Matt Spinelli or Kate Koss. I'm looking across to see if they have any questions, who have followed your work really closely in HIV, and want to ask about how you did this with COVID as well, and Orlando, I see you coming up.
Do you want? Sorry,
yeah,
do you want to
go ahead? Sorry.
Okay, that's all right. Thanks. All right. Good morning, Carlos. I want to wanted to just invite the question into the conversation around the politicization of just the COVID response itself, where we are, and what it means in terms of HIV, long-acting injectables for prevention and so on. If for some reason it seems as though we don't want to have the conversation around the politics of COVID and the public health implications of COVID are on this collision course. And so with this sort of like need to unmask, to just get back to normal, what does that mean for us in, say, in the short term and also in the long term when we look at the fluctuation in cases back and forth and hospitalizations and so on?
Well, you know, I think the you know, people are trying to figure out how to, as I said, how to live with COVID, and that is going to be messy. I think that's one thing we need to realize, that adapting to a new reality is messy. I think what we need to remind people over and over is that hopefully we don't go back to the past. We don't go back to what people call normal, because that normal was unacceptable, right? And I think if we learn something is you know, the enormous health disparities and the enormous inequality. So I wish we could go forward to a better place, right? In which, again, when I think about long-acting antiretrovirals, I mean, my biggest issue here about using long-acting antiretrovirals is that, you know, ADAP doesn't cover it. So we don't have coverage for long-acting, you know, drugs for treatment or prevention, for that matter. So, you know, that's a health disparity, right? That's an inequity. So we're going to see wealthy people or people who have insurance have access to these drugs, and people that don't have access to these drugs. And I think we need to really have, I'd love to see how we can get away from the politics and the partnership and really focus on coming out of COVID. I wish we can all be laser focused on health equity. I think at the end of the day, you know, health equity needs to be the driving force, and it has been the driving force for many of us in HIV for a long time. How do we make that truly be something that everybody worries about? I mean, you know, again, I talk to my colleagues that do diabetes. They've known for years that it's a much higher prevalence among minorities and the poor. How do we turn every single thing that we work on into a health equity issue, whether it's violence prevention, whether it's, you know, trauma prevention, whether it's diabetes prevention? And I think we need health systems that are truly focused on health equity, because if we do that, I think we will have probably learned the most important lesson out of COVID. And if we don't do that, I think we will probably miss the biggest opportunity that COVID ever gave us.
Could I just pick your brain one more time? I'm just thinking about the juxtaposition of COVID-19 vaccination and also LAI, as we're just going around that same thought. And I'm wondering, what are your thoughts on when PrEP first came out? There was sort of like this increase in studies around risk compensation, with a lot of folks following up to see whether or not folks were taking more risk and so on. And then you're also now seeing that same sort of like thing happening with COVID, with now vaccine just becoming just, you know, widely available. Folks are not wanting to use masks anymore. And so there's this other risk that the precautions have now gone away. And you've seen the same thing with PrEP for some people. What are your thoughts on that in terms of just moving away from the from even to continuing to mask or continuing to follow social distancing guidelines, similar to what we were seeing with PrEP?
You know, I think it's, I think it's a reality of human behavior, right? Humans are going to try to find a way to, you know, to do things that, as I said, but we're not very good at figuring out our own risk, right? So at the end of the day, what we need to be sure that we do is we don't shame people. Oh, you know, you got infected, you must have done something wrong. You did something wrong. And I think that to me is the biggest concern is, look, you know, with how transmissible BA2 is, as somebody said the other day in social media, if you haven't gotten infected, you probably don't have enough friends, you know? You probably don't have a social life, because the reality is that it's so transmissible that if you start living your life, you're going to get it, you're going to face it. You're going to get infected. And therefore, you know, recently we've seen, you know, Obama get infected and other people get infected. And, you know, it's not like they didn't take precautions. It's simply because, you know, this variant is out there and it's highly transmissible. So I think we also need to, as this happens, we need to get away from stigmatizing and discriminating people who get infected and seeing them as the enemy.
Yeah, I totally agree with this stigmatization that we seem to, there's so many moral words about this, around this. So I wanted to call on some of our junior investigators, Matt Spinelli.
I can ask a question since you already pre-called on me. Orlando stole my risk compensation question, but I think PrEP did make me think about some other issues with COVID, and sort of how I think it's really a shame that Evusheld, you know, maybe doesn't work so well with BA2, because I do sort of see the need for a PrEP drug for folks who don't respond that well to vaccines, or when vaccine efficacy wanes in at-risk populations. And sort of curious what you think of that and the ethics of that when drug supplies are so low, and also when the drugs maybe aren't so well tolerated.
Well, you know, I think, again, Matt, that the one thing that we need to, again, be humble and acknowledge is that the vaccines we have are also not ideal. We have a loss of a waning of immunity, and we need to understand if this is the you know, the antigen, if this is the delivery system, what is it? But, you know, vaccines don't have a great ability for protection. I mean, I've been, you know, fielding calls almost all day from people calling and saying after the study in Israel, why should I get a fourth dose? You know, what's the benefit if it's only going to protect me for a few weeks? You know, we can't continue boosting people every 3 months and hoping that this is going to get us out. I mean, something has to change, and I think the vaccines are going to change. I think monoclonals are going to get better. I think the people doing monoclonals are also going to understand, you know, what kind of drugs we need. The problem is that the drugs, no matter what happens, I think monoclonals are going to be in short supply. And quite frankly, they're going to be a big difference between the haves and the have-nots, not only in the US, but globally. I mean, talk to most people around the world, they don't have access to any of the monoclonals, and they probably never will. So how do we think about how do you think about a way to provide the best available therapy to everybody? And in my mind, that continues to go back to vaccination, right? It continues to go back to how can we ensure that people have access to vaccine, not only locally, but globally. And in my mind, that's going to take a really significant effort, because the number of people getting vaccinated is going down nationally, but it's not going back globally. So how do we do that? How do we make sure that we don't get our foot off the accelerator on that? Because my biggest worry, honestly, about the dialogue we're currently seeing in the US is the pandemic is over, then we're going to forget about it, right? And I think that will be the biggest mistake that we could ever make.
But when you said, you know, going back to I mean, I guess what I would say is that we've learned so much from COVID, that I actually think our treatments for other respiratory pathogens will get better. And I've never seen such a quick and amazing, I mean, if HIV if everyone was equally at risk for HIV, we would have gotten antiretrovirals a lot earlier than 1996. And I think the progress has been phenomenal. I feel like we don't talk enough about that. And these first generation antivirals are great, and they're 5 days, and they're going to get better, and they're going to take away ritonavir. And so it feels to what the progress is going to be is that we shouldn't accept such high deaths from influenza or RSV or other RNA viruses, and the antivirals for those are going to get better. Mm-hmm. And so are vaccines, which we don't have one for RSV. So, and influenza shouldn't be these clunky vaccines. So I feel like it's the other way too, that our, our work on other respiratory pathogens is just going to get better. I will turn to Steve.
Carlos, hey.
Hey, Steve, how are you?
Great presentation, interesting discussion. You mentioned aging, COVID's, HIV, and I'm going to say a fancy word here that I don't really understand, syndemics, right? Which I believe is when you have multiple epidemics hitting at the same time. And this is my clinical experience, right? I have a bunch of older guys that I follow in the clinic, and we've been struggling with HIV and aging. And I got to tell you, when the pandemic started, they all quickly went into their, they shut down because they knew all about public health issues, and I've been struggling to get them out. So they've been sort of very isolated, a lot of these guys, for a couple of years now. And I've been struck by how older they seem. I mean, of course, they're 2 years older, but I do worry, and Monica's talked about this a lot, that there's synergies that have occurred in terms of these multiple hits on our HIV infected population, social isolation, some of the biology of aging, the polypharmacy stuff. This all is accumulated into sort of health effects I don't think we're really talking about, but I actually think I see in the clinic. I'm wondering if you're seeing that as well.
No, I agree with you. And I think I've seen it not only in patients with HIV, but in patients without HIV, right? I mean, is that older population has not gone out and, haven't seen their grandchildren, haven't seen anybody, and they're living in a essentially not only by themselves, but actually with now significant, depression and mental health issues. And I think that has been a huge challenge in dealing with older populations. I mean, people who, the other day I went to see somebody at a long-term care facility. I mean, I was like the person from outer space or from Mars. They hadn't seen anybody in a year, right?
I think that's what you need to figure out what you have to do to keep people safe, but also take care of other needs.
But how do you get back to, how do we get also the message we told people is, you can't go out, this is going to kill you. Now we need to somehow change the message a little bit, right?
And how well vaccines work. You said that they didn't work that well, but they do, at least against severe disease. And that's been really phenomenal to see. Aisha.
Thank you so much, Dr. Del Rio. That was a phenomenal talk. As a combined addiction medicine and ID fellow, I love the focus on anti-racism. And I'm curious what you think or how you think ID as a field needs to incorporate anti-racism in training fellows or future ID providers.
That's a really good question, and something that, I think we need to think more about. But I think obviously there are a lot of things about discussing race from that perspective, right? In other words, don't talk about, I tell people that we need to stop talking about race as a risk factor, and really think about how do how do we discuss, how do we do it in such a way that we discuss race not as a risk factor, but as a risk marker of vulnerability, of bias, of systemic disadvantage. And I think even in our case presentations, rather than talking about, a 65-year-old African-American man with newly diagnosed HIV, we talk about, we learn to tell our fellows, how do we probe further into what that means as far as vulnerability and systemic disadvantage of that individual that led them to then have HIV. Is not because they're Black, it's because all those other things. So I think that would be one place that I would start, right? It's really trying to dig deep into the social vulnerability component. The other thing is, I think that what we all learn is the importance of activism, right? As in HIV, if something changed the course of the pandemic, was activists, right? And we all need to be activists, and scientists work together with community and activists to change things. So I think we all somehow, I think there's no specialty in which activism has to be incorporated into what I think it needs to be one of our competencies. And the best way to deal with addiction is activism, right? You're not going to be changing the opioid epidemic by getting more buprenorphine prescribed, but you're going to change it by changing policies that lead to increase opioid addiction. So I think activism needs to be part of what we do, and therefore, part of what we need to learn is how do we speak to legislators, and how do we speak to decision makers, and how do we communicate to those decision makers, because that's where we can really have an impact.
Thank you.
Thank you. And Judy Auerbach has been saying some really great things in the chat, so I'm going to have her unmute, please, and tell us about some of the work. I mean, I think what really struck me about what you said, Carlos, is how we didn't involve social behavioral scientists, anthropologists, others that helped formulate our response and what people were willing to do in terms of even uptaking the vaccine. So wanted to see, Judy had some comments about this. Thank you, Judy.
Thanks, Monica. Can you hear me okay?
Hey,
Yes.
Judy, how are you?
Yeah, sorry, I'm not presentable, so I'm speaking behind my still photo at the joys of working at home and not thinking you're going to be speaking. In any event, I really appreciate the opportunity to say some things out loud. Most of you know me as someone who can easily be identified as a bit of a shrew and an activist around behavioral and social science and the integration thereof with biomedical and clinical science. That's been an ongoing project. I think the thing that's been interesting and challenging from COVID that connects back and forth to HIV, as Carlos mentioned, is that there are a whole lot of folks, particularly MDs and even some basic scientists, who've become much more aware of and now speak about things that have been in the domains of behavioral and social sciences forever. So a lot of the words we heard today, a lot of the key points Carlos made, as I mentioned, are well researched and have to some extent been well addressed by behavioral and social sciences, people who are trained in psychology, sociology, anthropology, political science, as you articulated, Carlos. And the difficult thing is that we don't read across each other's literature, and that's a big part of it. And so it seemed during COVID for many of us in the social behavioral sciences, we were hearing people not trained in our disciplines speaking about things that are in our domains and for which there is a great deal of research, either historically or currently in COVID. At the same time as vaccines and therapeutics were being researched, so was misinformation and miscommunication and political incursions into public health, vaccine hesitancy, vaccine confidence, inequalities in access and uptake, and all of those sorts of things. So I think it's really great that we're having a lot more people from the medical community engage on these issues. And I think my key point always is just to not feel like you have to reinvent the terms, reinvent the literature, rename them. There is a lot of literature out there, and there are a lot of experts out there who could be engaged from the get-go. So a number of us have been advocating here and there in lots of different ways around the point that both Carlos and Monica mentioned, the lack of high-level involvement of social behavioral scientists in pandemic responses. It seems there's less of that in the US than there may be in other places. Some colleagues in the UK say there actually were some social scientists engaged very early on in the government's response. But we don't seem to do that very well in the United States. And so anything that we all can do to enhance our conversations across our disciplines, you know, I'm all for transdisciplinarity, or what I'd rather call disciplinary pluralism. I don't need to be a virologist. I hang out with virologists. We talk about cure research, but I'm not going to give a talk on virology. So we just sort of would like the same respect in that you know, we all learn who the people are and we engage and invite them to be the spokespersons from the point of empiricism, from the research that has been done. So that we can get beyond some of the broad statements that we continue to make around COVID and around HIV that we all know to be true at this point. We just need to engage the evidence a little bit better in some of these conversations. So thanks for giving me the opportunity to be shrewish.
I don't
Funny, I don't
think
look
you're at all.
shrewish.
I think that's actually extremely fair, because when I think about our messaging problems from the public health establishment in the US, it's just been a couple of people giving all the messaging, and I think they would have benefited from more social behavioral and more compassion from that point of view. I also, Carlos, remember this is going to be a winter of death and suffering for the unvaccinated. I don't think that was a great line. Any other questions or anything else you want to say, Carlos? Our next session is actually our Excellence Awards for the CFAR. We give out 3 Excellence Awards every year, and we're super excited to hear from them. And Jonathan Fuchs and John Ciceda will be leading that in a couple of minutes. But any final comments from you, Carlos?
My final comment is you guys have a tremendous CFAR, and again, goes back to showing how the HIV research community pivoted and started working on COVID and continues to be at the forefront of a lot of the response in COVID. And, you know, I see Steve's, for example, the work he's doing on COVID and how that relates to the work he's been doing in HIV. So over and over, I think that you know, the environment that you have at UCSF, it's a great environment to then, you know, find your, I would tell you, just junior investigators, find your passion, pursue it, and you'll be supported and you'll be successful. Because the reality is, if you're passionate and you work in a successful and thriving and, you know, caring environment, you will thrive. You will be successful. So continue doing that, because at the end of the day, you'll have a very exciting career by doing that.
Thank you again so much for being here, and
I'll continue listening.
Than we did in California.
Okay.
Thank you so much.
Take care. Bye.
So I'm now going to turn it over to Jonathan Fuchs and John Ciceda, who are the co-directors of our mentoring program for our next hour, which is, we're super excited about, again, Excellence Awards. Please stay on to support our 3 awardees.
Thank you, Monica. Apologize for the noise in the background. So hi, everyone. As Monica said, I'm John Salceda. I'm co-director of the UCSF-Bay Area CFAR mentoring program, along with my colleague and co-director, Dr. Jonathan Fuchs. And so for those of you who are new, the CFAR mentoring program is now in its 17th year of operation. It's designed to help develop the scientific career goals of early HIV investigators and postdoc scholars. And in 2015, we started giving out awards that recognize the work of remarkable ESIs in translational, behavioral, clinical, and basic science. And so these early career research excellence awards are our way of highlighting the successes of our CFAR members. And on behalf of Monica, the other CFAR leadership and staff, we would like to say just how proud and excited we are to be introducing our 2022 awardees.
Thanks so much, John. So it's my pleasure to segue to Dr. Peter Hunt, who's going to introduce our awardee, Dr. Diana Alba, who's receiving our Early Career Excellence Award in Basic and Translational Research. And you all know Dr. Hunt is a professor of medicine in the Division of Experimental Medicine and is co-director of our UCSF CFAR. So without further ado, Peter.
Thanks, Jonathan, and it's my pleasure to introduce Dr. Diana Alba, this year's recipient of the Excellence in Basic and Translational Research Award. So Dr. Alba got her MD at the New York Medical College and then completed her internal medicine residency at the University of Miami, after which we were fortunate enough to recruit her here to the UCSF Endocrinology Fellowship. And during her fellowship, she joined Sunil Koliwad's laboratory and began a translational research program focused on the mechanisms by which adipose tissue dysfunction and fibrosis might contribute to insulin resistance and diabetes, providing novel mechanistic insights into why people with some racial ancestries develop diabetes at lower BMI than others. And some of those same pathways may be operative in HIV. She's led a series of studies with Sunil and me, exploring the inflammatory and adipose tissue specific pathways that contribute to diabetes risk in treated HIV infection. She will share some of that work with us today. She's a rising star in our field, recently being awarded a prestigious Robert Wood Johnson Foundation Harold Amos Career Development Award, and also giving an oral presentation recently at CROI 2022 based on much of the work that she'll share today. So please join me in welcoming Dr. Alba. We look forward to your talk.
Thank you, Peter. Let me go ahead and share my screen. Great. Okay, well, thank you so much for the introduction, Peter. I am honored to be here today to present our work. And again, I am an endocrinologist, but thanks to our collaboration with Peter, I have been able to explore all of these interesting questions about HIV, adipose tissue, and metabolic dysfunction. Okay. So just to give you some background about my project, it is well established that insulin resistance is a key driver of type 2 diabetes. We also know that people with HIV are at increased risk for developing type 2 diabetes, and this has been linked to persistent inflammation. However, the specific pathways driving the risk have not been completely characterized. And so in addition, we also know that in obesity, you get this unhealthy expansion of adipose size, which is linked to hypoxia, inflammation, as well as fibrosis. And this causes a spillover of excess lipids to the visceral adipose compartment and other non-adipose tissue organs. And since we know that HIV and other co-infections like CMV can live in the fat, we actually wonder in the context of HIV, whether inflammation in the adipose tissue itself might contribute to fibrosis and a lot of these pathologic conditions, even in people who are not obese. And so we wanted to do a study where we not only look at the systemic inflammatory predictors of insulin resistance, but we also wanted to see whether there are differences in fibrosis in the adipose tissue as well. So our first objective was to assess immunologic predictors of insulin type 2 diabetes using a case cohort study within Cynics, which is a large multi-center cohort. And then we decided to assess the relationship between inflammatory markers, insulin resistant, and adipose tissue fibrosis in ART suppressed people, people with HIV and people without HIV. And so here we're leveraging a case cohort study among adults with ART-mediated suppression for 1 or more years. We randomly selected 968 participants. We excluded the people with prevalent diabetes at entry. And so we have a total of 843 participants and 97 had incident diabetes. And so using a Cox proportional hazards modeling, we evaluated the relationship between inflammatory markers measured at 1 year of viral suppression and the risk of incident diabetes. And so as you can see, our cohort consists of 843 individuals. The people who developed type 2 diabetes were older with a mean age of 50 and a median BMI of 30, so also higher. There was a tendency for people who developed type 2 diabetes to be women, and the majority of people who developed type 2 diabetes were Black or Hispanic. And as a reminder, these are all participants are virally suppressed for at least 1 year. And so a multivariate Cox proportional hazards model were fit to assess the relationship between the biomarkers and type 2 incidence. And so here you can see the biomarkers are on the left, on the y-axis, and the hazard ratio is centered on the cohort interquartile range around the x-axis to facilitate comparison between or across the biomarkers. And so as you can see, several biomarkers are associated with increased incidence of type 2 diabetes, such as IL-6, KT ratio, and soluble TNF receptor 2. And so after we established these distinct patterns, we actually were interested in assessing the extent to which immune activation might actually differ by natal sex. And so here you can see that while the inflammatory markers tended to predict incident diabetes, similarly in men and women, we actually found a very striking interaction. And that's that cellular TNF receptor 1 exhibits a qualitative interaction where it actually predicted diabetes in men, but not in women. So again, very interesting, something we still don't fully understand, but we need to further explore. So then our next question was, how might inflammation actually mediate an increased risk for insulin resistance within the adipose tissue? So in our current study, we enroll a cohort of people with and without HIV and without type 2 diabetes, but we actually stratified these people by hemoglobin A1C to actually get a dynamic range of insulin resistance. This is a very well characterized cohort. We have DEXA scan data, abdominal MRIs. We also have stool samples from microbiome, plasma serum, as well as oral glucose tolerance test data. And in addition, we also have in this cohort, we actually collect abdominal subcutaneous adipose tissue samples using a liposuction technique that allow us to obtain up to 10 grams of fat that we use for various studies. So some basic characteristics from this cohort, we have included 34 people without HIV and 41 people with HIV. Both groups are have very similar distributions of men, women, similar BMIs, as well as A1C. But the people with HIV the group of people with HIV is slightly older than the non-HIV group. And so we wanted to find out if there is actually a relationship between adipose tissue fibrosis, visceral adiposity, and insulin resistance in people with HIV. And so as I showed you before, pathologic expansion of adipocytes leads to adipose tissue fibrosis. And there is actually substantial evidence that adipose tissue fibrosis is actually linked to metabolic dysfunction, both in mice and in humans. And so to assess fibrosis in the adipose tissue, we actually measure hydroxyproline levels by a colorimetry assay as a quantitative measure of collagen deposition. And this is because hydroxyproline is actually a major part of collagen. And so measured hydroxyproline levels have been shown to correlate to the levels of collagen present in tissues. And so we actually found that people with treated HIV have higher levels of fibrosis compared to people without HIV, as measured by hydroxyproline levels. And what was even actually more interesting is that when we divided the groups by BMI using a cutoff of 30 to actually mark obesity, we found that people with HIV had significantly higher levels of fibrosis, particularly among lean people who aren't supposed to have that much fibrosis to begin with. So in HIV negative people, you generally only get fibrosis when you're obese, but in HIV, in fact, you already have fibrosis even when you're lean and you don't have that much fat. And so we then assess the relationship between the fibrosis and the subcutaneous adipose tissue, visceral adiposity, insulin resistance, and all of the inflammatory biomarkers that we measure in the CYNIC study. And so as you can see, HOMA-IR, an important indicator of insulin resistance, actually correlates nicely with hydroxyproline levels, with visceral fat, and many other measures of adiposity and body fat distribution, such as percent body fat and waist-hip ratio. HOMA-IR also correlated modestly with some of the markers of inflammation as suspected here with the HIV negative group. But as you can see in the HIV positive group, you see that nearly all of the biomarkers of inflammation are associated with HOMA-IR. So there's some major differences in the interactions between the HIV infected group and the HIV uninfected group. The other association that was actually very striking was actually related to fibrosis as measured by hydroxyproline. And so as you can see, fibrosis correlated with HOMA-IR and visceral adipose tissue and some of the inflammatory markers in the HIV negative group, but not in the HIV positive group. So there's in the HIV positive group, there are hardly any associations between any of the markers I mentioned. So the big picture is that there is far less of a correlation between markers of inflammation, visceral adiposity, insulin resistant with hydroxyproline levels in people with HIV than there is in the HIV negative group. So there is some kind of disconnect between the surrogate marker of fibrosis that we're using and insulin resistant in HIV. Okay, so we know there is a link between fibrosis in the subcutaneous adipose tissue and insulin resistant in the HIV negative group. And we also have shown that people with HIV have higher levels of subcutaneous adipose tissue fibrosis, but actually no clear correlations with visceral adiposity or HOMA-IR. And so actually to explore or determine if the increases that we see or the increased risk for the development of insulin resistant in and the increase in adipose tissue fibrosis in the people with HIV actually derive from similar changes in adipocyte gene expression, or whether each reflects unique changes in the adipose tissue when compared to people without HIV. We assess the differences in the whole subcutaneous adipose tissue gene expression in people with HIV and people without HIV. So we actually use a targeted nanostream platform, including 770 genes that have been linked to fibrosis. We did this on mRNA data on 81 people. So we included 35 people with HIV and 46 people without HIV with very similar metabolic profiles. So again, all of these participants do not have a history of type 2 diabetes, and they have A1C levels less than 6.5%. So as you can see, the groups are very similar to, except to sex. Our HIV group has significantly lower percentage of women when compared to men. And so here is the gene expression profiles of the whole subcutaneous adipose tissue of the people with HIV and the people without HIV. So the volcano plot on the left is showing you the distribution of the full change in expression. The dots labeled with the genes in blue are the ones considered as differentially expressed. And so as you can see, there are many upregulated genes and then some downregulated genes here. I don't have time to go into much detail, but as you can see, there are many interesting genes. So for example, dipeptidyl peptidase 4 or DPP4 is highly involved in glucose and insulin metabolism as well as immune regulation and is upregulated in the people with HIV. SERPIN1 is a well-known inhibitor of fibrin degradation, and the overexpression contributes to accumulation of extracellular matrix. It has also been implicated in the pathogenesis of obesity, insulin resistant, and type 2 diabetes. And again, it's upregulated in the people with HIV. Interestingly, collagen 4 is actually downregulated in the people with HIV. So there might be other potential pathways related to fibrosis that we need to explore. So again, a lot of interesting data that I need to kind of look more into detail. So our next steps are actually to integrate this data with the inflammatory, the imaging, and the insulin resistant markers that we have generated in the cohort to actually very characterize the specific pathways that appear to be associated with insulin resistant and treated HIV to actually identify targets for intervention. And so in conclusion and for further studies, many inflammatory pathways predict insulin type 2 diabetes in treated HIV infection. We found that sex modifies the association between TNF receptor 1 and insulin diabetes, such as that TNF receptor 1 actually predicts diabetes in men, but not in women. And people with HIV have higher levels of adipose tissue fibrosis when compared to the HIV uninfected people. But while fibrosis is closely linked to inflammation, insulin resistant, and visceral adiposity in people without HIV, it does not seem to be linked to those same factors as well in people with HIV. So some potential explanations, maybe this is a drug effect. Maybe adipose tissue fibrosis in HIV is more driven by ART drugs. So for example, integrase inhibitors have been recently linked to fibrosis. And so maybe this particular mechanism of drug-induced fibrosis might be unlinked to the inflammation, fibrosis, and insulin-resistant axis. And so to assess fibrosis and better understand this disconnect between hydroxyproline and insulin resistant, we're actually working with our colleagues from radiology to use various imaging techniques to measure fibrosis in the abdominal subcutaneous adipose tissue compartment. And finally, subcutaneous adipose tissue transcriptome data might provide novel clues linking inflammation to insulin resistant in people with HIV, as well as the mechanistic basis for increased subcutaneous adipose tissue fibrosis in HIV. And so finally, I want to thank all of the collaborators, our amazing study participants, CFAR for funding, as well as my mentors, Sunil Koliwat and Peter Hunt. Thank you very much.
Diana, thank you so much for an excellent talk. We have time for questions. So Michael, there's a, if you want to come off mute.
Hey.
That'd be great. Thanks so much.
Can you hear me?
Yes, perfect.
Hey, I really enjoyed your presentation, and it's really exciting to see the IDEO data start to come out. So that's really cool. I had some questions about whether you've thought about these issues with regard to COVID. So there's some evidence for diabetes occurring after people have COVID, and there's also some preprints I've seen of that claim direct infection of adipose cells during acute COVID. And then in our long COVID cohort, it seems like BMI predicts long COVID, and long COVID is also associated with systemic inflammation measured in blood. So I'm wondering if you think that any of the work that you've presented suggests that similar mechanisms could be involved in COVID or long COVID, even though the time scale between infection and kind of outcome is much different.
So that's a really good question. And actually something I forgot to mention is that our cohort is actually a longitudinal cohort. So we see people at one time point, and then we actually bring them back 2 years later to assess or to actually determine who develops type 2 diabetes. So we have been bringing people back right now, and we have been asking them questions about COVID infection, vaccination. When they come in, we collect plasma and serum, and we also check insulin and fasting blood glucose and hemoglobin A1C, and we ask them questions about who has developed type 2 diabetes or what medications they're taking. So there is definitely something that we can look into because, again, we have the follow-up data.
Great, thank you. Any other questions for Diana? Peter, please.
Yeah, I can ask a question. The DPP4 signal that came up is really striking because we have inhibitors for that, don't we, that are used for diabetes. You wonder whether this might be a pathway that's particularly important in type 2 diabetes and HIV, and whether those drugs might work better in people with HIV than the general population. What do you think?
Yeah, that's a really good point. And the other thing I was thinking about when I saw our data for the nanostring was GLP-1 receptor agonists, right? And those are medications that we're using for weight loss that work wonderfully for our patients. And I know we're using it a lot in the HIV population. I'm not aware of any data about GLP-1 receptor agonists, if they work better in people with HIV, but you kind of kindly shared the data about the sitagliptin that there was a study performed in treated HIV within the ACTG. Since there was this idea that maybe had some anti-inflammatory properties, and it actually failed to reduce inflammation in people with HIV without type 2 diabetes. I will probably have to go back and look and see if there's any specific data about people with HIV and DPP4s. But as far as what we saw with the nanostring, how it's upregulated in the people with HIV is really interesting and definitely something that we kind of want to further explore.
Thank you so much. If there are no further questions, Dr. Alba, congratulations and thank you for your excellent talk. And we'll turn it over to you, John.
Thank you.
Yeah, congratulations again, Diana. And so for our final award, it's my pleasure to introduce Carol Dawson-Rose, who's going to be introducing Dr. Orlando Harris for our 2022 award for Outstanding Research in Clinical Science. Carol.
Thanks, John. Hi. It's my pleasure, it's my honor to introduce Dr. Orlando Harris, who is the recipient of the CFAR Excellence Award in Clinical Research for Young Investigators. And also want to note that Dr. Harris is the first nurse scholar to ever receive this award, so that extra congratulations there. Dr. Harris is an assistant professor in the Department of Community Health Systems within the School of Nursing. He holds a joint appointment in medicine in the Division of Prevention Science at CAPS. Dr. Harris completed a postdoc at CAPS prior to coming over to the School of Nursing. He brings his expertise in methods and approaches to achieve racial equity in COVID vaccination, and he's brought that to the COVID vaccination prevention network that NIAID funds. He is the recipient, I believe it starts this month, Orlando, this week, last month, a K23 award for his project, Jamaica Cares, which is connecting HIV/AIDS resources to engage Jamaican sexual and gender minorities. Orlando, congratulations on your award and take it away.
Thank you, Carol. Let me go ahead and share my screen. Okay. Awesome. I think I did this before. Presenter view or slide view?
You're good.
Okay, awesome. Okay, excellent. Thank you. All right. So good morning again, everyone, and thank you so much for the warm introduction, Carols, and for the to the CFAR leadership for the award. I was really excited about Carlos's talk this morning, and then listening to the conversation in terms of also Paul's talk too as well, and just to see how my talk just sort of like complements all of that. And I went ahead and put together a presentation that is not data driven, because this is a call to action sort of a presentation. So it's looking at vaccine hesitancy and long-acting injectable HIV treatment and prevention modalities. And so we're the goal is to move us toward access, equity, and trustworthiness. So far, we know that COVID-19 has disproportionately impacted racial and ethnic minorities and vulnerable populations, and the need for the increase in vaccination outreach among these groups is sort of a matter of equity. So we're seeing relatively high COVID-19 morbidity and mortality that have been documented in older adults, people with chronic health conditions, low socioeconomic status, and the underinsured, and those from racial and ethnic backgrounds. Now, since then, there was a speed to develop the vaccines against COVID-19. And we saw with the development of an effective vaccine against COVID-19 virus, it was a major accomplishment of science and was seen as the primary public health strategy to reduce infections and deaths, thereby ending the pandemic. Yet vaccine hesitancy put in peril the goal of controlling the spread of the virus, particularly among communities that are greatest at risk of contracting the virus and dying from it. Now, the reasons for the lack of COVID-19 vaccine uptake among some communities in the US, they're multifaceted, some of which includes concerns about safety and effectiveness of the vaccine, the speed in which it was developed, disinformation about vaccines, and of course, systemic barriers affecting communities' access. So we look at the online appointment systems, inadequate transportation, the lack of childcare, and for many communities of color, including African Americans and Latinx individuals, COVID-19 vaccine reluctance is rooted in both historical and contemporary experiences of medical mistrust and racism and forced sterilization of Latinx women in California. And of course, I can point to Tuskegee as well. But I will say promoting vaccine uptake among the 70 million people that are unvaccinated in the US is among the most urgent challenges that are facing us today. And so when we think of what's out there now and connecting what we've learned from COVID and vaccine hesitancy to pre-exposure prophylaxis, we know that we have oral PrEP, which was first approved back in 2012. And then recently in December of last year, we now have long-acting injectable cabotegravir. And so while the number of people using PrEP has significantly increased over the years, there's still large disparities that do exist, and they often fall among racial, sexual, and gender lines in terms of sexual and gender minority people. And so the most impacted folks who are vulnerable to HIV are least likely to benefit from this advancement. And I remember one of my other mentors, Greg Millett, who often said that for every advancement that we make in biomedical prevention, we often create new disparities for our communities. And so because we know that already, we don't necessarily need to start over. We just need to take those lessons and move forward. And so looking at some of the data that we have here, so according to the US Centers for Disease Control and Prevention, notable gains have been made in increasing PrEP use for HIV prevention in the US, and preliminary data show that in 2020, about 25% of the 1.2 million people for whom PrEP is recommended were prescribed it, only 25%, compared to only about 3% in 2015. We've made progress, but not enough. People aged 25 to 24 years old account for 63% of all PrEP users and also 54% of all new HIV diagnosis. And we still see that HIV itself and PrEP uptake in the South continues and remains a challenge. And of course, nearly 50% of PrEP users in 2017 were located in just 5 states, and that's New York, California, Florida, Texas, and Illinois. And those states accounted for about 37% of US populations and presented 46% of all newly diagnosed with HIV in 2016. And of course, New York, Massachusetts, Rhode Island, Washington, and Washington, DC are among those 5 states or districts with the highest rates of PrEP in 2017. So what do we know? I went to the literature just to see, since PrEP was approved back in 2010, what was the state of the science from then to now? And there've roughly been over 1,000 articles that have been written on barriers and facilitators to PrEP uptake. 1,000. Many of those papers are from researchers like yourselves who are in this room. I was pleased to see some of those citations. And over 200 of those articles focus on Black, African Americans, and Latinx individuals. So we know all of those things. And I hope to God that we don't see another 1,000 papers on barriers and facilitators to long-acting injectable PrEP. We already know that they do exist. So what is already known? For various reasons, Black African-American men have lower PrEP uptake. Large racial and ethnic disparities exist in terms of PrEP awareness. Limited discussions about PrEP between Black African-American patients and their providers compared to their white counterparts. And those with low PrEP care engagement have also been shown to have lower rates of HIV testing. And then individuals and systemic barriers impede access to healthcare and PrEP. So how do we use those lessons to, one, increase access, equity, and trustworthiness of long-acting injectables? So some potential challenges that we can already foresee. Clinics that provide CAB for PrEP need to have facilities and protocols for storage and administration. That's roughly about $5,000 per injection per patient. They need to have the mechanism for tracking patients, and of course, support adherence to a Q or every 2 months injection. And then, of course, plan for identifying and managing those who are late to injections or lost to follow-up. And then, of course, what we've learned from PrEP was that there were racial bias in prescribing patterns, and this led to discrimination and as a result of racism. So how do we overcome those challenges? One, clinics will need to develop workflows and systems that ensure that those at highest risk for HIV can access CAB, ensure that adherence support is available, make sure that the patients who are late for injections are identified quickly, and encourage them to adhere to injection schedule. And of course, provide training to all staff on diversity, inclusion, cultural humility, and of course, empathy. And I was very fortunate to be a co-I on an empathy study here at UCSF using virtual reality. And of course, end racial bias in prescribing PrEP. Now, there are individual challenges as well in terms of socioeconomic factors, financial and housing concerns. We saw from Dr. Wesson's talk around folks who are returning citizens and some of the challenges that do exist, inadequate health insurance coverage, competing life demands, which can make adherence to injection schedules difficult. And of course, a lot of lessons from COVID around vaccine hesitancy, and it centers on trust in the safety and effectiveness of CAB versus oral PrEP, and of course, medical mistrust. And then there are also other individual challenges that leads to how do we achieve equity? So achieving equitable access and uptake of CAB for PrEP will require addressing those socioeconomic factors that I mentioned earlier: financial and housing assistance, increase access to medical insurance or Medi-Cal, medication assistance programs. Carlos mentioned in his talk that ADAP and other services are not covering injectables at the moment. That presents a challenge. Flexible clinic hours and locations to overcome scheduling challenges. And that might include weekday evenings and weekends hours for clinics, mobile clinics, et cetera. And then thinking about socio-demographic approaches. So individual interventions using the stages of vaccine readiness and action and health coaching techniques to decrease hesitancy and increase uptake. And of course, use an anti-racist approach to demonstrate to patients that all are welcome in your clinic. And I will say, just to point to the stages of vaccine readiness and action and how it can be applied to move folks from being skeptics around long-acting injectables, those who might be curious, those who are ready for it, make sure that you eliminate those barriers, providing with them, and then of course having adherence programs, peer navigators to ensure maintenance. And now I'm happy to say that we just published this in a forthcoming issue of AJPH, looking at using health coaching to get people to increase to uptake vaccines. And then, of course, just my last 2 slides or so, I would say that in terms of trustworthiness, doubt and skepticism about science, research institutions, and governments are not easily overcome for a lot of communities of color. And of course, persistent bias, discrimination, and the dearth of BIPOC clinicians in the healthcare system is well documented. We know this already. So these factors can lead to poor COVID vaccine uptake, and long-acting injectable cabotegravir uptake as well. And then we see disparities in access to vaccines or CAB that have negative effect, which can lead communities of color to feel abandoned or neglected. The same was with PrEP, in terms of providers weren't having these conversations with their patients of color, specifically Black and Latino MSM, and we saw glaring disparities as a result of that. And of course, building trusted relationships between patients and providers, it requires us to actively listen to each other and ensure that barriers and challenges are addressed. And finally, I will say, in terms of some of the recommendations, a 2001 Kaiser Family Foundation survey found that 79% of US adults who have not yet been vaccinated say that they will be likely to turn to a doctor, a nurse, or other healthcare provider when deciding to get vaccinated. And so nurses can play a crucial role in engendering trust in vaccines and also injectable CAB. As healthcare professionals, nurses, and other public health workers are often the patient's first clinical contact among the most trusted sources of information about vaccines, and so we should use them. Yeah, nurses are leading the nation's vaccination administration efforts in terms of COVID vaccination efforts, and to many are the most accessible source of information for questions around safety, side effects, and benefits. But to be effective, nurses and other public health workers require an understanding of the reasons that prevent people from getting vaccinated or accessing CAB, and must have the practical tools to support people with their decision around if, when, and how they get vaccinated against COVID-19 or access injectable cabotegravir. And of course, I will say that at the practice level, nurses and health professionals have a duty of care that extends beyond the clinical and research encounters to that of activism at the micro level, and hence why this is a call to action for me. I would like to thank my mentors as well, including Carol Dawson-Rose, Sherry Weiser, Mallory Johnson, Jay Chavez, and of course, John too as well, and Monica Gandhi. And of course, a special acknowledgement to the CFAR for supporting my Our Lives Matter project, where this work came out of. And I'll stop sharing.
Thank you so much, Orlando, for that outstanding talk, and congratulations again. So please raise your hand, type a comment in the chat for Orlando, and Monica has your hand raised, so I'll let you kick it off, Monica.
Well, I just wanted to say, Orlando, you just have been someone to watch. These years that you've been at UCSF, it's been a joy to watch how well you've done. I think you're pretty modest, but your K just got funded. And you're doing great, and we were thrilled to give you the award this year, and I think you're doing the kind of work, especially around trust, that is imperative going forward. We have to have people trust us and for COVID, and so you're especially around vaccines. So thank you so much. I actually just wanted to say thank you for your great work. And Diana, I'm sorry, I meant to say you were doing great work too. It's amazing. We're really proud of all of our CFAR excellence awardees.
Great, thank you. Yeah, Jonathan.
Orlando, fantastic talk. I really appreciated the discussion around structural barriers around PrEP uptake, and specifically in Black and other people of color. I was just curious, thinking about Dr. Nika Seidman's presentation during CROI, and looking at potential facilitators for uptake for contraceptives, and looking at additional choice as a potential facilitator for uptake. And I'm wondering, just curious about your thoughts about having additional options and the way that those options are presented, how that might actually facilitate uptake.
Yeah, I think that's a great question, Jonathan. And I will say, it's true that we now have oral, now we have injectables and so on. And I'm also excited to hear that there are other forms of injectables, not every other month, but maybe every 6 months, that are currently that's being done in terms of the trials. And I'm excited for that, because I think the more options we have in the toolkit, the better it is for communities to access and to feel, a huge part of it is also feeling seen. And I think, I've had this conversation with a number of people, participants in my own research, but also in the community. And I asked them about the likelihood of, or the potential to take injectable PrEP. And to be honest, I think it's been a mixed bag. You have folks who are treatment experienced in terms of those who are on ARTs, and they're saying, listen, I know my pills, they work. And you're telling me you're going to inject me with this thing every couple of weeks. I'm not too sure about that. And I'm also hearing the same concerns for folks who are HIV negative, who are saying the same thing, to say, hey, I take my PrEP, I'm used to it, I know my pills, they work. And so I think the reason for this talk is to help us get ahead of some of the hesitancy that we're going to see, and help us get ahead of some of the disparities that are likely to come.
Thank you.
Thank you, Orlando. Carol.
Sure, thanks. Thanks, Orlando. That was amazing and very inspiring. Thank you. One of the questions that I have is really around, you talked about so many different modalities to increase, or decrease hesitancy, health coaching from the individual level to some of the things at the system level, and what we can do to think about in terms of loss to follow up, or using some of the models that have been really effective to reach hard to reach populations, or that are hard for us to reach populations as clinicians, which is having our doors open to people who drop in for appointments. Even during the week, but on the weekend, evenings. And we've seen that with the Max Clinic in Seattle, and how well it's worked with people who are persistent substance users and have complex mental illness. But I don't see much movement from us. I'm not sure what my question is, but how do we move our systems to adapt to what is needed? That is a low threshold in order to address some of the needs that you're talking about, whether or not it's with COVID, vaccination, or with the PrEP.
Yeah, so thanks, Carol. I think what we need, if I can answer your question in less than 30 seconds, I think what we need is sort of like, we did a shift where we took so many of the lessons learned from from HIV, and we transferred that into doing COVID work. And so we have made a lot of inroads on the behavioral side with COVID. And I think we're at a crucial moment where we need to take all those lessons back from what we've learned from COVID, we have improved with COVID, and bring it back into the HIV world to make sure that we do have equity. And I'll finally say, I would hope that we don't come here 10 years later and we have another thousand studies on barriers and facilitators of long-acting injectables. We have done it all, and communities of color, we want action. I think that's what I'm calling for.
Thank you so much, Orlando. And thank you for everybody for staying and supporting our outstanding awardees. Give them a big round of applause. And so with that, Jonathan, any final words you want to say to the group?
Congratulations, and thank you all for participating in your support of our early stage investigators. Outstanding work, and really excellent presentations. Thank you so much for being with us today.
Yeah, thank you. Have a good day, everybody.